Hi all, it's Danny, DC Injury Clinic. I've put together a little presentation on knee pain. I'm going to look at various causes of knee pain, why they occur, and a few opening gambits of what you can do to self-manage during this time. Lots and lots of causes of knee pain is the first thing we should say. Always say to people clinically, knees are rubbish. And I say that half jokingly. They're just very susceptible to injury. The first one we're going to look at, PFPS, is patellofemoral pain syndrome. Patella being your kneecap, femoral femur, your thigh bone, pain, ouch, syndrome. Anything medically speaking, which is a syndrome, means that we don't know 100% what's causing your pain. You're a kind of walking, talking bunch of symptoms, as it were. So PFPS will generally present as general knee pain. Lots of people feel it at the front, the anterior of the kneecap, or underneath, sort of underneath that kneecap, that kind of pain. Generally considered to be in the overuse. I never really like that term, but a kind of overuse category. Potentially someone who's increased training load or changed surface, or it started high intensity or high impact classes. That would certainly correlate with someone presenting with PFPS. There's a lot of research into people with PS can present as having an internally, so inwardly rotated thigh bone femur or an inwardly rotated tibia shin bone. And they will generally, we would expect to see a level of poor flexibility or mobility, particularly in the quadriceps, the muscles at the front. How you would recognize it is, and there'll be a lot of crossover in a lot of these injuries, but generally people would say going up or downstairs is hard. That there may be swelling, not always, and there may be muscle wastage, but again, not always. Generally, that's something that is a clinical symptom rather than someone walking in and saying, I can see that my thighs are wasting away. So the next one is iliotibial band syndrome. Very common in runners, this one. Some people call it runner's knee. Again, umbrella term, not a massive fan of that. But this is lateral knee pain, so pain on the outside of your kneecap. Generally, this is progressive, as in it will, the pain or symptoms will raise their ugly head at a specific time during your exercise. Normally, for runners, anything between 2 and 4 kilometers or 3 and 5 miles, that's when the pain will set in, and it's very, very consistent. It's generally thought to be caused by poor hip strength, so the ability to control the knee when you're running. The hip should be controlling the knee in the frontal plane. So again, goes under that overuse category potentially. Sometimes localized tenderness, so on the outer edge of the knee, sometimes there's a tenderness there. And sometimes if we're looking at someone's running gait, for example, they might have what we consider a crossover gait. So some people may report that they've started kicking their own heels when they're running, for example. So those legs are coming across the midline where that knee's dropping in. It was always considered that iliotibial band syndrome was the iliotibial band itself flicking over a bony prominence just below the bone. But now we know it's much, much less glamorous than that. And actually the pain itself seems to be caused by a fat pad that sits between the tendon, the iliotibial band, and the bony prominence. For those of you who are unfamiliar with iliotibial band, it's this thin fibrous tissue that runs alongside the outer thigh, goes right from your gluteal muscle right to the top of your lower leg bone, like Gerdy's tubercle. And like I say, underneath there, there's a fat pad that's very highly innervated and causes a great deal of pain when it's frictioned. So ligament damage, generally acute injuries. So something's happened in a sport environment, a rugby tackle or football tackle, for example. Sometimes there's an accompanying pop or click when it happens, and you would have a natural instability afterwards where the ligaments, there's 4 main ligaments, a lateral on the outside, medial on the inside. At the front, you've got your ACL, anterior cruciate ligament, and at the back, the posterior cruciate ligament, and they are stabilized in the knee joint. Around 70% of ligament injuries are non-contact. So poor landing mechanics are hugely important. I talk a lot about how we see lots and lots of people now doing box jumps and things like this, which are great, but if we can't land properly, I'm not sure we should be jumping as high as we are, or at least let's learn to land before we learn to jump. Meniscus is what we would, in layman's terms, call your cartilage. Again, can be an acute onset, so something's happened, someone's wiped out your knee, you've been wiped out by a dog at park run or something. People report it's painful when the knee pivots. So a classic is getting in and out of your car. Really, really painful to get in and out of the car. There's no clinical test for that. I've never come across a course that uses that as a test, but it's almost fail safe. If someone comes in and that's the key thing that they're telling me is the painful part of their day, we would certainly be looking at the meniscus. Sometimes there's a clicking or a grinding, not always. And again, it doesn't mean that if you've got a clicking or a grinding, it doesn't mean that you've got a meniscus issue, but they can accompany meniscus issues. Really painful to deep squat or to try and hyperextend through the knee, so really straightening the leg. People with meniscus issues will generally find that the knee loses the ability to fully extend, but like say, vice versa as well. Deep squatting will be very, very painful. Some people, the knee will lock or it will give way, particularly on stairs, but again, not always. And an arthritic change, which is what we would generally call osteoarthritis, or what I would call the gentle caressing of time. It's a degenerative condition. So it's age-related, generally over 50s, but not solely. We would see it in the younger population as well. Again, similar to meniscus issues, a lot of crossover, grinding, clicking potentially, maybe a lock-in, maybe giving way. Risk factors would be obesity, sporting history or history of knee injury in the past, in your younger years potentially, or genetics. We don't know too much about how hereditary it is, but it seems to be that if it's in the family, if you have osteoarthritis or osteoporosis in the family, then you are more likely to have it. The arthritic change itself is the smooth cartilage on your bones starts to degenerate. And so where it's designed to be a shock absorber or to create smooth movement of one bone on the other, where that cartilage is degenerating, again, a completely natural thing, it loses its ability to do both of those things. There are a couple of differential diagnoses. So Baker's cyst, for example, which is or a popliteal bursitis is the fancy name, which is a swelling behind the kneecap. And also a neurological pain. So generally anything from your lower back, if you've suffered from lower back historically, and now you're getting knee pain, it could be a neurological issue. Anything between L3 and L5 of your lower back will refer pain right through that knee joint. So always worth considering. And if you're not sure, of course, get it checked out by someone. So these are the areas we would expect to see your pain. Again, fairly vague this, but patellofemoral PFPS, patellofemoral pain syndrome, will be general knee pain. Arthritic change of meniscus can be full knee. Meniscus generally, I would expect to see more medial, this front lower aspect, not always, but that would be the most common area I would expect to see it. Ligament, again, we've got a lateral ligament on this side, medial ligament on this side. Generally, they're the ones we would see most issues with, particularly medial, but that's not to say that the anterior cruciate ligament and the posterior cruciate ligament aren't at risk. You'd be very, very unfortunate to do your posterior cruciate ligament. In 10 years doing this, I've never seen a fully ruptured PCL. And then iliotibial band syndrome, again, on that lateral outer edge of the knee, very, very consistent, that one. But going back to the arthritic change, what we know is that hurt does not equals harm. If we look at cartilage damage, for example, on this scan, this is a graphic by Adam Meekins, who's well worth following. We can see that 68% of people with no pain have cartilage damage, which means that we can say without a doubt that cartilage damage on its own does not mean pain. So even if you go for a scan and you're shown cartilage damage, it doesn't necessarily follow that it is the cause of your pain. It's something that's worth bearing in mind, but hurt does not equal harm. So for those of us who run, research will tell us over and over that our risk of osteoarthritis in the knee and the hip decreases for runners, but that doesn't mean that the knee isn't at risk. 35.2% of running injuries are knee-based, which isn't a surprise when we consider, particularly if we're running fast downhill, up to 11 times body weight is going through the knee joint. Certain things do seem to correlate. For example, running volume, more likely to get knee pain, so PFPS or iliotibial band syndrome, whereas the faster we're running, we're more likely to have Achilles type pain. So that's the more volume, the greater the volume. If we've suddenly increased our mileage, we're more likely to get knee pain. And footwear is interesting. Conventional cushioned shoes seem to correlate with a higher prevalence of knee pain. There's an inverse relationship with running footwear particularly, whereas the more cushioned the shoe, the higher the force impact through the knee, which is worth bearing in mind if you're someone who's suffering with knee pain and you've considered going to a more cushioned shoe. Again, it's worth having a read up on or dropping me a message because the research actually doesn't support that at all. So the first thing we're going to do with any knee pain is our P.O.L.I.C.E protocol, which was formerly the R.I.C.E protocol, rest, ice, compress, elevate. We've removed rest now because rest is not always best, and we now know that actually long periods of rest have negative effects where the tissue changes in a negative direction. We can use, if needed, things like taping or braces during the protect stage. But these are not a life sentence, so we kind of use them to get out of them. Optimal loading is a fancy way of saying let's get it moving and get it functionally strong again as soon as possible, regardless of the cause of our pain. Ice, we don't know as much about ice as you would like to think we do, but it certainly seems to be great for pain management and is better than using synthetic drugs putting into our system as pain relief. So ice is great for pain relief. Compress, so simple things like the tubey grips are fine. Again, there's not always going to be a swelling, but there doesn't seem to be any negative short-term effects from using a compression bandage. And then elevate, nice and simple. And there's a blog link at the bottom there if anyone wants to read a bit more about the whys of that approach. So key muscles, there's a few key muscles really. The quads at the front, your thighs, they're extending the knee and stabilizing your kneecap and keeping the patella nice and centrally. So as we bend and straighten the knee, the kneecap should stay relatively central in its groove. And then the hamstrings at the back, which are flexing the knee, so bringing your heel to your backside, but they're also stabilizing the knee joint. So as you're landing, whether that's walking or jumping or running, the hamstring should be engaging to stop your knee from hyperextending. Third set that we're going to look at are the lower legs, particularly the gastrocnemius, so the bigger the calf muscles, what you consider your belly muscles. For other injuries, we look closer at the soleus, particularly Achilles tendinopathies. But for knee, we're going to look at gastrocs. Reason being, they cross the knee, so they're finishing high above the knee, whereas the hamstrings are coming down and they're finishing below the knee. I think we like to think of things very in their box. The hamstrings come to the knee, the calf comes up to the knee, but actually they're both crossing and fighting for the same job. So we'll look at some videos. Quad strength, one of the first things that we lose, as I've alluded to earlier, with a knee pain is the ability to fully straighten the knee. So one of the first things I like to do with anyone with knee pain is ensure that we maintain knee extension. So once this is loaded up, we've got a few options. It's that final 15 degrees of motion that quite often is the first thing to be lost. So we're going from there to there. So I get people to roll the towel up place it under their knee, push down and hold for 2 seconds, and then relax for 2 seconds. You can do it weight bearing, so get a squidgy ball or a towel behind the knee, again, force it into the wall, working on that extension. And then if you want to make it harder again, just add some resistance, get a strong resistance band, and work against it to ensure we don't lose or we look to regain that knee extension. From there, we can make it a bit more weight bearing, a bit tougher with a little exercise I call heel drops, which confuses everyone because I think everyone else calls heel drops calf raises or similar. Heel drops, again, same premise really. We're making sure that we're not losing that knee extension. It's just a more functional weight bearing way of doing it. You don't need to have a step. I'll show you the way I do it on the step in this video. You don't need a step. You could do it on a flat surface and just toe tap away. But essentially, we're ensuring the hips stay square. We're bending the knee to about 15-20 degrees. That's the heel we're dropping. So the non-active leg is being dropped and working back up. Really nice exercise just to ensure that that quad muscle at the front isn't wasting. And we're, like I say, I'm over-egging it, but we're ensuring we're not losing the knee extension. From there, we're going to go on to a bit more of a functional exercise. So single leg squatting. Two leg squatting is absolutely fine as well, but most things in life are single leg, walking, running, most sports, all single leg exercises at root. So I like to do split squats. You don't need a weighted bar. The movement is what we're after. So try and ensure the knees are facing forward. You see my knees working really hard to stabilize there. Knees not going in front of the toes. I don't over emphasize that. But they're really nice exercises to try and keep the quads working. So, hamstring strength. Do a lot of work with hamstrings. It's really important these muscles at the back are strong and engaging, as, like I say, they should be the brakes of your knee and stopping your knee from continually hyperextending. So we've got hamstring bridges there. The differential between that and a glute bridge is if my feet were back here, that would be a glute bridge. Further the feet are away, more hamstring. And that's in that position. I get people to work statically or isometrically. So I would look to be holding that for about 45 seconds, 5 times. Once people are comfortable doing that, very simply, get them to do what we call chair raises. So minimal equipment needed again. There's lots of amazing exercises you can do in the gym, but realistically, most rehab is done at home. So really important, similar to what I was just saying about the bridging, the angle of the knee is important. If my backside was any closer to the chair, that would be gluteal dominant. But because we're about 45 degrees away, it's going to be hamstring dominant. And then we progress to single leg. Much, much tougher than it looks. So gastroc, again, like this is the upper portion of your calf muscle. So simple calf raises. Won't show you a video for this. My favorite approach is I go 2 legs up, hold at the top, take 1 leg away, hold for 2 seconds, and then lower for 3 seconds. So we're going through a concentric contraction up with 2 legs, an isometric contraction or a static contraction for 2 seconds, and then an eccentric or lengthening contraction going down, which is where all the magic happens. This is a paper looking at patellofemoral pain, so PFPS, in females. A lot of research in knee pain is in females. 70%, I think it's 70% of knee pain in females is actually a hip condition. And this paper supports that. So it says that studies demonstrated better results when treatment combined hip and quad strength compared to just quad strength. So to that end, we look at something called the Trendelenburg Gait, which is essentially if there's any weakness in one of the hips, the opposite hip will drop. If that opposite hip is dropping, the knee tends to drop in on the other side. So the stance leg starts to collapse inwards, something we would call knee valgus. Lots and lots of research in knee valgus. Correlation doesn't mean causal, but it does correlate with a lot of knee pain, that knee dropping across the midline, and again, that crossover gait. So I get people to do what we call crab walks. So I go back to the video. Crab walks are a lovely little exercise that I get lots of people to do. There's various different exercise on this video. There's 3 different types, but crab walks are my favorite. All you need is a TheraBand or an exercise band around the ankles. Always get people to put it around their ankles. We want long levers. See lots of people doing these with the band around their knees, but we want longer levers. So always have the band around the ankles. Always keep it tight and just wander around your living room backwards and forwards, minute at a time, a handful of times throughout the day. Really get those deep gluteal muscles working. And that will, in time, help with any potential hip collapsing inwards. How do you know if you're doing it right? Essentially 24 to 48 hours after exercise. If you've got no soreness at all, you might need to do a little bit more, work a little harder. If you're still sore at 48 hours, incredibly sore, you've probably done too much. And so we're looking for that sweet spot straight in the middle, soreness that settles quickly. So I hope that's been helpful. I hope there's been a few little bits that if you've got knee pain, you can start chipping away at. If you did enjoy it, if it has been helpful, I've got an 80-minute webinar that's on my website aimed at runners, and that's available to download now. Also written a book which has got over 130 pages and similar treatment advice as we've just been through for over 20 different injuries. And of course, if you need me, I am available for video consultations. So yeah, like I say, hope it was useful. Feel free to share if it was. And these are all the various ways you can keep in contact with me and let me know how it was or if you need any further help.